Perfect.
Okay, so hello everyone. Before we start today, I want to acknowledge with respect the Indigenous peoples and communities whose historical relationships with the land continue to this day and on whose traditional territories our work takes place. While we meet today on a virtual platform, we can take a moment to acknowledge the importance of these lands, which we each call home. So my name is Autumn Sipis. I am a project manager for the Canadian Coalition for Green Healthcare, and on behalf of the coalition, I would like to welcome you to today's Cut the Carbon Beyond the OR session, Environmental Sustainability in Medical Imaging. Throughout the event, please use the chat function for any technical issues you may be experiencing. Use the Q&A function for any questions you have regarding the presentation, and Maura will be answering questions at the end of the event today.
Great.
We are also recording the presentation. The recording will be sent to all registrants and will be available on our YouTube channel at a later time. So today we have Dr. Maura Brown. Dr. Brown is a radiologist at BC Cancer Vancouver and is a clinical associate professor at the UBC Department of Radiology. She has a lifelong enjoyment of the outdoors and love for all living things, which led her to interest in biodiversity loss, climate change, and the associated risks to human health. She is dedicated to work on reducing emissions and waste in healthcare with a focus on radiology. She co-chairs the Canadian Association of Radiology, Environmentally Sustainable Medical Imaging Working Group. It's a lot of words.
Oh, no
And
kidding.
the BC Cancer Planetary Health Unit and chairs the BC Radiological Society Environmental Sustainability and Medical Imaging Working Group. Um, okay, so
We need an acronym for all those words.
yeah, for sure.
Yeah.
I
Did
know
you
I
get
feel that
the
way. I did
email that I
hear.
sent you? Okay, perfect.
Yeah, downloading now.
It'll just take a sec. While she's waiting for the download, there'll be a little title slide, which just introduces me and the title for today, Environmentally Sustainable Medical Imaging for the Canadian Coalition for Green Healthcare. And I'm thrilled to be here and thrilled to have all of you here. I hope you find it interesting. And I also hope that everybody is well in these tumultuous times. Um, so Autumn, please go ahead with the first one when you have it ready. And I apologize everyone for the delay. We had some technical problems on my end. Wonderful. Okay, so the next slide then is my land acknowledgement. Today I'm speaking to you from the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh peoples. I respectfully acknowledge that among many things, the impact to our extractive colonial settler environment has had on Indigenous culture and ways of life. Next slide. I have a few disclosures. I'll talk later about a project that I'm doing, which is funded by Doctors of BC and some various speaker honoraria. Next slide. I know this is a very well-informed audience, so I've decided not to go through my usual talk about the health impacts of the climate crisis, and I'm instead going to focus mostly on medical imaging and the environmental impact. Then I'll outline some effective low carbon and low waste strategies in radiology that are specific to radiology within healthcare, and then describe some opportunities for collaboration amongst healthcare professionals across various disciplines to advance sustainability in medical imaging. Next slide, please. As you will have heard many times, the Canadian healthcare system accounts for 4.6% roughly of our national greenhouse gas emissions. Medical imaging departments are very resource and energy intensive. And in a 2023 paper by Picano, they estimated that radiology accounts for 0.8 to 1% of total global emissions. Radiology contributes to emissions and waste through the manufacture and operation of our large resource-intensive machines and the use of single-use plastics. Like many spheres of medicine, radiology departments worldwide are faced with the challenge. The emissions that we create by providing care contribute to the adverse health effects of air pollution, environmental degradation, and climate change. Next slide. In this graphic is from a recent publication by McKee et al., and it shows where radiology fits into the planetary health system. On the left are the biggest impact areas. As I mentioned, our machines use large amounts of energy. In areas where scope 2 electricity is generated through burning of fossil fuels such as gas or coal, this can be the biggest single factor driving radiology carbon footprint. We also use a significant amount of single-use plastics and generate substantial waste in both diagnostic and interventional imaging. We use finite resources such as iodine, gadolinium, and helium. Iodine and gadolinium also contribute to water body and environmental contamination. And on the right is how radiology, along with the rest of the healthcare system, add to the negative feedback of emissions by causing healthcare-related impacts, which then end up requiring more healthcare, which exacerbates health inequities and other social determinants of health. Next slide, please. This is a recent paper by Thiel et al. Where they did a life cycle assessment of a teaching hospital radiology department in the US. This department included 3 MRI, 4 CT, 4 X-ray and fluoro units, and 2 ultrasound machines. The greenhouse gas emissions of the whole department over a year equaled that amount to power 1,100 gas-powered cars. This paper and the graphs are quite information dense, but I think it's important to draw your attention to the purple bars, which is the energy used. So as I mentioned, when the grid intensity is high, for example, mostly fossil fuels, then the purple bars are large, and we can reduce that when we advocate for renewable energy sources for electricity. For all the imaging modalities here, MRI, CT, and X-ray, this is the single largest contributor to the emissions in most settings. MRI was 48% of the total emissions, and the total clinical use of the department, 54% of it was the electricity use. Next slide, please. This is a 2020 study from Switzerland where they looked at just the scope 2 energy use of an imaging department of a large hospital, similar size to the hospital that was looked at in Virginia more recently. They found that the entire department used the energy equivalent of 854 people living in 4-person homes, or the same amount of energy as driving over 2 million miles in a gas-powered car. And the emissions impact, as I mentioned, varies widely depending on the grid intensity. Next slide. This is a recent paper by Kate Hanneman and her colleagues in Toronto looking at the increase in imaging utilization in emergency rooms due to short-term exposure to heat and poor air quality. This is a negative feedback loop where on smoky days, there's increased medical imaging utilization, which causes more emissions and a negative feedback, and the same for days where there's extra heat. This is an important perspective, providing another window into the impact of medical imaging on total greenhouse gas emissions. Next slide, please. I'll move on now more to talk about what strategies exist within radiology to support sustainable healthcare practices. Next slide. Many of you will be familiar with this framework by Andrea McNeil and her colleagues as a helpful way to think of how healthcare can become more low carbon and sustainable. So I looked at this from the point of view of radiology. In the first tier of reducing demand, there's not too much that radiologists and radiology departments can do. We can we do provide disease reduction strategies through screening programs and health promotion. Next slide, please. So this second tier, I'm going to elaborate more on in the second part of the talk, but it's basically to ensure that the right care is delivered to the right patient at the right time. And this includes avoiding unnecessary investigations and treatment. In our current resource-constrained healthcare system, systemic efforts to address overuse and low-value imaging simultaneously reduce demand, reduce wait times, and improve the patient experience. So there's strong motivation from many different sectors of the healthcare system to act on these initiatives. We can examine workflows, scheduling, and staffing to ensure that the standby time of MRI and CT scanners is reduced, and we don't have wasted appointment spots, and we don't waste our capacity. All that being said, each patient's experience is unique, and it is important that we do not end up avoiding or delaying care, because this could result in more advanced disease, which ultimately requires greater resource utilization. So it's a balance that we have to find between to provide the best care in the right patient in the right time. Next slide, please. So I'm going to circle back a little later to talk more about that tier 2, but for now I'll just focus on tier 3, which is once we've decided that we have a medically appropriate imaging test to perform and we have a department doing medically appropriate imaging, then what is the best way to reduce the environmental impact of the services that we need to provide? So by improving energy efficiency of our equipment, by looking at building emissions such as room temperature control, supply chain, and sustainable QI. Many of these overlap with all the rest of the healthcare decarbonization that the Canadian Coalition of Green Healthcare is doing so much hard work on. But there are a few things specific to radiology that I think are helpful to consider. Next slide. So this is just, I've used this slide many times in talks to radiology departments too. So there's things here that overlap. I'll spend a little bit of time talking about education and energy use, but I'm not going to go too much into food, buildings, supply chains, and transportation because those are so well covered in other topics and other areas. But education and energy use are important. Next slide, please. It's quite clear through the projects that we've done that educating technologists, clerical staff, operations teams, radiologists, and patients really can't be overstated. Understanding what is happening to our planet with the ongoing burning of fossil fuels and the impact this is having on our health and the paradoxical contribution that we make to this problem when we provide help is really important, and it's fundamental to engagement. People need to understand the why and then the how, and then we'll be able to reduce the barriers and get some change and design some inclusive and specific solutions. Next, please. So as was mentioned at the beginning, I co-chair the Canadian Association of Radiology. This is a big mouthful, but Environmentally Sustainable Medical Imaging Working Group. So we published a statement on environmental sustainability in medical imaging in 2024, which is available it's published, so and it's open access, and it provides the recommendations to guide the diverse teams that make up medical imaging in Canada, including technologists, radiologists, medical imaging leadership, industry partners, governments, and other key stakeholders as we transition towards a more environmentally sustainable, climate resilient radiology surface. And in this paper, it's unique to Canada, and we've given special consideration to the geography and the variety of medical imaging workplaces in Canada, considering rural and remote locations and inclusive and social and environmental determinants of health. Next, please. So the CAR working group also published a second paper. We had really enthusiastic support from our trainees at all levels. And this is a collaborative statement with their input on planetary health. It's their future, and it reflects both current literature and their needs as trainees. It includes recommendations for a national database of projects, a recommendation to establish a certificate in sustainable medical imaging, to embed research and quality improvement into academic training programs, and to offer support for trainee-led interest groups and engage a wide variety of other parties, including Indigenous peoples and medical imaging vendors. Next, please. Most of you will be familiar with the playbooks that Cascades has been building, and we did one with Cascades on environmental sustainability in radiology. And this was the scalability and reach of this project was enhanced by the fact that we're able to pull that the CAR was also interested in this work. And so it's co-branded and provides a bigger audience really than and a different type of audience than either group on their own. So hopefully has a wider impact through that opportunity. Next, please. So next, to talk a little bit about the energy use and waste that happens in medical imaging, we can think about this in production phase or in use phase. So the production phase includes the raw materials, manufacture, shipping, installation of the equipment. The use phase is the energy required to operate and cool the equipment. The image I showed you earlier of the department LCA by Thiel and her colleagues found the clinical use phase is about 54% of the total departmental greenhouse gas emissions. Now, we have to always consider that in that that is dependent on the grid intensity for the scope 2 emissions. So that number will vary depending on the actual location that the imaging department is. But for where they were in the US, it was about half, which means the other half is the production phase emissions, which is the manufacture of large equipment. And you can see it's significant. Producing one MRI machine is the same as producing 76 cars. CT is about 3/4 of that, and ultrasound is much smaller. all of the medical imaging vendors now are developing reuse, refurbishment, and updating equipment protocols. So rather than entirely replacing new equipment, they can reduce the production phase emissions by about 50%, which is also a big cost-saving measure, both on the renovations required and on the equipment itself. So again, a win-win for everyone, whether you're in administration or procurement, or whether you're on the purchasing or the operations side of the radiology team. Next, please. And this again is the 2020 study from Switzerland where they looked at powering of CT and MRI. Things have actually changed a lot in the 5 or 6 years since this was published, but they found at that time that CT and MR, and this is still true where it hasn't been addressed, it's inherently inefficient because up to 2/3 of the energy is consumed during the idle system state. So when the machines are turned off, or sorry, in a non-clinically useful state, so overnight or in between patients. We can't turn our machines completely off because they do need to keep the detector array at a certain temperature, but they can be powered down to lower power. And we've done some work on that in BC, which I'll show you in a moment. And the same with MRI. There's a waste of energy during system off state or between patients or when it's not being used for a few hours overnight, for example. Next page, please. So most MRI machines, again, this is historical and things are rapidly changing, but first off, most use large amounts of helium, liquid helium, which maintains the cold temperature that is needed to make a superconducting magnet. This is kind of a unique problem in medical imaging because these machines can't be completely powered off, but they do more and more have increasingly vendors are providing eco power mode so they can be turned to a slightly lower power. Vendors are also developing very low helium machines, which are up and coming. So they'll be replacing the existing stock eventually. This study in 2023 looked at the possible power savings if a eco power mode was used for 12 hours overnight on all outpatient MRI in the US. And you can see the numbers are enormous, both in terms of kilowatt hours saved and the dollars saved by being able to turn the power down when you're not using it. Next page, please. So our group here in BC, we did a pilot study on the scanner where I work at BC Cancer, and then we did some local work regionally, and we engaged through the Lower Mainland, which was 37 different sites. And after that was published, we received a Quality and Innovation Project grant from the Perioperative Clinical Action Network of BC, which is a subcommittee of the Specialist Services Committee of Doctors of BC. And so this was a regional project, which became a provincial project. So we presented the regional work at the PCAN Summit in 2025, and now we're in the midst of gathering the rest of the data for across the province. Next slide, please. So this is the process map that did both the regional project and the provincial project. We had a team of radiologists, technologists, we had a medical physicist, business analyst, and facilities engineers. We learned quite a few things with this project. So while the work powering off scanners when they're not being used or putting them into lower power mode definitely saves electricity and saves money, there's challenges. This map showed what we went through. So it turns out that in BC, in the Lower Mainland of the 37 scanners, only a third of them were on the yes side of the graph. The other 2/3, we either couldn't put them in a lower power mode because it wasn't available on the type of scanner, or because the scanners were being used too often. They're 24/7, like in big emergency rooms and major hospitals, or some single sites that are that serve a large population. The scanner runs 24/7. In those cases, there's no practical time period to power down. So once we sorted through the third that we could power down, we put them into 3 different clinical use groups. The high ones were the ones that were excluded, and low and medium were used various amounts of times overnight. And out of those, we did show some significant savings, and we have some learning. So if you can just go to the next. I haven't published the table with all the savings because it's embargoed. It's still going through final drafts, but there were some lessons learned from this project, which I think are really helpful. It's really important to have a diverse team of people involved in the project. It's not just radiologists and it's not just building engineers, but you need everybody. It's important that we have biomedical engineers involved early. It's also important to acknowledge that not all scanners currently support low power modes. And one of the things that I would like to suggest in this project is that when we have an RFP for medical imaging equipment, it should include an automatic eco-power mode as a sustainability criterion, because there are large energy and cost savings to be obtained. And the necessity at the current time of this being a manual process does cause some limitations in how it can be scaled. So by having an eco-power mode that's automatic, you can then make it what's called a forced function, and you don't have to depend on people worrying about whether the equipment will work or whether they remember to do it. Next, please. This is an interesting comparison of two studies. So there's a 2014 study and then another one 10 years later. Both showed significant power savings by powering off PAC stations, which are radiology imaging workstations at night. But interestingly, in 2014, they modeled the savings, but then they actually didn't experience the savings because people forgot or they didn't want to, or whatever, the human factor. But then in 2024, they had an automatic power down protocol installed, and they actually did realize the savings. And the other thing is there were no reported workflow disruptions or complaints from the end users. There are limitations to what medical imaging workstations can be powered down because of various limitations due to IT. There's concerns about updates, overnight updates, and other system factors. So again, like with the CT scanner, this isn't available everywhere. And in fact, hasn't even been implemented in BC because of various concerns. Next, please. So another, just a little bit of talk about the sort of general facilities, the meso level actions that are specific to radiology. This is quite interesting. It's similar to an OR. This is an interventional radiology suite. They did an LCA. And interestingly, the biggest impact you would have thought maybe it was the plastic, but it was actually the scope 1 or building emissions because of the tight temperature and humidity control that's required of these rooms. And so they found that by relaxing those controls when the room isn't used over weekends or evenings, they can save emissions and save money, very similar to operating rooms. Next, please. In terms of reducing waste, this is another example that's quite specific to radiology. As we move towards multi-dose dispensing systems or multi-patient systems for contrast, this study from Vanderbilt was, I think, 2023, where they compared the two single dose versus multi-dose systems and found that the multi-dose reduced the waste by 73%, reduced the plastic waste by 93%, and saved a whole bunch of money by not wasting as much contrast, by not wasting as many single-use syringes and tubing. So most sites that have a decent volume of patients now use multi-dose dispensing systems. Next page, please. So as you know, iodine is the contrast agent that we use for a CT scan. 96% of iodine comes from Japan or Chile, and it's a byproduct of oil and gas extraction. The extraction cost is high with a large environmental impact. And as we wind down oil and gas, it's going to become more expensive. So there's, again, a win-win to recapturing and recycling iodine, both reduced environmental impact, and it's a good action for vendors to potentially save some money. Many of these recycling programs are just in development, but it's important also because when this particular opportunity where contrast that's left over, 10 cc's here and there in a 500 ml container at the end of the day can be collected in these jugs, sent back to the factory, and the iodine extracted. It saves the iodine from being washed down the drain. Iodine itself is inert, but when you combine it, or when it actually doesn't get captured by the filters on municipal waste systems, and so it goes out through them, and then it can combine with chlorine and other disinfectants, and it can create toxic byproducts. So the less goes into the environment, the better. And the same with gadolinium. We know that there's increasing amounts of anthropogenic gadolinium in our global waterways, and people are just, working on how to deal with that. Reducing use, obviously, is one, and recycling and recapturing projects like this are important as well. Next, please. So this was from a paper we did in 2023, and this has actually been adopted in the procurement teams for many places in BC, and it's basically to add sustainability criteria as a part of the evaluation in a request for proposal to purchase medical imaging equipment. And we haven't updated this yet with the information about needing an eco power mode, but it would be into a framework like this that would be most appropriately fitted. Next, please. So this is the slide that you saw earlier. We went over some opportunities at the micro and meso level to engage staff and optimize energy use in medical imaging. I haven't talked about food or buildings other than the specific to do with the IR suite and supply chain also. I talked a little bit about that, talking about refurbishing equipment. Most of the other things are in line with other work that's going on in ORs and other places. And same with transportation, both of staff and patients is ubiquitous to healthcare. So I'm not going to expand more on those at this time. You guys know all that stuff. So next slide, please. I'd like to now talk a little bit about opportunities that we can collaborate among healthcare professionals to advance sustainability in medical imaging. Next, please. This slide you saw before, and I just want to go back and focus on the right patient, right time, right test component of medical imaging. Next, please. So this is a paper from 2023, I think 2024, where they looked at US data from 2017 to 2021 and looked at the trends in imaging utilization and estimated the high and low end impact of the average yearly greenhouse gas emissions that come from inappropriate exams. So this is American data, and we may not have the same rates of inappropriate imaging, but the sort of the fundamental point is that it causes significant excess greenhouse gas emissions. And so reducing low value imaging is a system action that can help both the emission side of the problem, but it can also help with wait times. And there's many patient factors and system factors that are benefited by reducing low value imaging. So I'm going to go into this in a little bit more detail. I think it's also interesting to note here that although the MRI units themselves use more energy than CT, because CT is ubiquitous and so heavily used, the actual impact of addressing CT is potentially higher in absolute numbers. Next, please. So low value imaging or medically appropriate imaging. So it's the medically appropriate imaging is to reduce low value imaging. So low value imaging itself is imaging that does not contribute to reducing overall pain, dysfunction, or suffering of the person that is examined compared to alternative actions. And low value imaging or over imaging can result in more harm than benefit and may not change the clinical management of the patient, and it may not be cost effective. So if we focus on medically appropriate imaging and reduce low value imaging, it improves the quality, safety, effectiveness, efficiency, and sustainability of imaging services. Next, please. This is a logic model that further illustrates these concepts. It's from the same paper, and it talks about how low value imaging may cause more harm than benefit, how as an action it does not change clinical management, and also it's not cost effective or efficient economically. So these are not, this is separate even from the environmental impact, but from that slide I just showed you with the excess carbon emissions, we know that this is also a hugely important action for sustainability. Next, please. So this is a recent paper in the CARJ where they looked at what strategies might exist within a resource-constrained system, which is what we work in Canada. We're short people and we're short equipment. How can we best provide the highest quality of patient-centered care in a low-carbon and climate-resilient manner? So we can increase capacity by extending hours, hiring more people, hiring more radiologists. There's challenges with all of that because there's not enough. We can improve efficiency by making sure that our machines are run, that we schedule patients tightly and that we're efficient with the time that we have of our techs and such. I'll just skip over the low value imaging for a moment. We can prioritize capacity, making sure that each machine is running at its fullest extent before we buy and build more. And then we can integrate AI into workflow and helping in, making sure that we aren't doing duplicates and making sure that we're doing the optimal workflow, having, for example, if a patient's coming for one test, scheduling another test the same day so that we don't have them driving back and forth. So next slide. If we actually focus on the reducing low value imaging and reducing demand, automating flagging of duplicates and flagging of similar orders. That's another opportunity for AI. We can introduce and integrate clinical decision support tools into our digital healthcare structure. I'll talk about that in a moment. And then I think one of the most important actions is collaborating between providers to address this really complex problem of patients wanting exams, providers wanting exams for their patients, costs and administration, and working together so that we help each other to make the system function better. This requires education and engagement, and it probably requires updating clinical practice guidelines. Next, please. So the use of clinical decision support tools is the use of evidence-based guidelines to support clinical decision-making. It helps to assist referring doctors in selecting and practitioners to select the most appropriate imaging modality. And the goal is to improve the quality and consistency of referrals while we reduce unnecessary imaging and promote patient-centered best care. Next, please. So in Canada, there are several websites that you can go to. Anyone can use these. They're open access. The CAR has published some referral guidelines which have been updated as of 2025. The ACR has appropriateness criteria for medical imaging, and Choosing Wisely Canada is an interdisciplinary collaborative approach to reducing duplications and waste and other things in the healthcare system. Next slide, please. This is not a new paper, actually. It was one of the earlier papers about quality improvement in medical imaging. And I found it quite interesting to see where the appropriateness tool, I put a big green arrow onto so this is a table from the actual paper, but how far upstream in the system, appropriateness needs to be placed. So it's not something that happens when the requisition arrives in radiology, but this is a collaborative piece. It goes way upstream to where physicians and patients interact and have their encounter, decide on what is the next best test to do. And if the physician wants some assistance, then there's those websites that I listed on the prior slide to help guide their discussions. Next, please. So the CAR, like all specialty groups, has collaborated with Choosing Wisely, and the updated Choosing Wisely medical imaging situations that are endorsed by the CAR added 3 more, the numbers 6, 7, and 8. And basically the existing ones were several things to not do unless there's red flags, and they're described in the Choosing Wisely information. And then things like not to do CT for appendicitis in children, not to do ankle x-rays in adults for minor injuries. And then the new ones are focused on MRI. So not to do MRI without considering ultrasound first for rotator cuff pathology, not to order MRI based on an x-ray for query femoral acetabular impingement unless there's actually clinical findings, and not to order MRI of the hip or knee if osteoarthritis is more than mild, because the MRI is not going to alter the clinical management pathway for the patient. Next, please. Choosing Wisely on that same page with all the radiology listings includes quite a number of patient education resources, which are really helpful to engage patients in that upstream decision encounter between the patient and the clinician to ensure that shared decision-making is possible, that everybody contributes to making smart and efficient and effective choices. This is a way to help promote patient-provider communication, and this information helps to ensure that we have high-quality patient-centered care that is time and free from harm. Next, please. So even with all of this, Kai and Choosing Wisely Canada in 2022 reviewed 12 treatments and tests, and they found that there had been improvement over 5 years. However, of those 12 tests and treatments that were looked at across community, emergency, and hospital care facilities, 4 did not decline in use, and of those 2 were imaging related. X-rays for low back pain and CT for minor head trauma without red flags. So it shows that although we're on the right path, and this is something people are talking about, we definitely have work to do to educate our providers and our patients and engage everybody in helping us all to have a better healthcare system for everybody. Next, please. I work at BC Cancer, and we just started on a really interesting project that choosing wisely doesn't name any specific oncology follow-up imaging recommendations. So what we've done here is we've started a collaborative project with medical oncology and radiology. We're just getting going, but the idea is to engage oncologists and patients in that upstream early encounter to help plan the path and discuss the best way to manage imaging going forward. We've engaged patient partners and we have some wording that will help to convey the information that medically appropriate imaging is safe and effective care, and that being imaged at the right time and by the right team for the right exam is high quality care. We currently have 15 oncologists actively engaged, and we're collecting data over the next sort of 6 to 12 months. And this project is site and tumor specific. However, we're hoping that we can collect significant data or helpful data, and that this can be scaled and implemented across other sites and other tumor sites and other oncology sites. But we'll see. That's just getting started. But basically, next, please. It came from the fact that access to timely and appropriate CT scans during cancer treatment is integral to monitoring results, but we really have a supply-demand mismatch, and this is ubiquitous. Everyone is dealing with this. And we know that delays in imaging are not good. So how do we address that, which ties in with the whole environmental question as well? Next, please. So by imaging the right patient at the right time, we will hopefully reduce demand and have some impact on the supply-demand mismatch, reduce wait times, improve the patient and provider access to imaging, reduce the waste of contrast and electricity, reduce risk to the patient. You don't want people to have unnecessary radiation, unnecessary contrast. And also one of the things that happens with imaging sometimes is the workup of incidental findings adds more to their stress and adds more to the environmental impact. So overall, we want to improve the patient and provider experience. Next, please. I just made this. I thought it was fun. I know AI is bad, but I was having some fun with this. Next, please. So in closing, we've talked about how radiology is energy and emissions intense. There are multiple opportunities to improve the environmental sustainability at the micro, meso, and macro level. Reducing in terms of a collaborative opportunity, reducing low-value imaging is essential to quality patient care, improving access and equity, reducing unnecessary radiation, contrast, and reducing unnecessary workups, and overall reducing the environmental impact of medical imaging. For providers, there's frameworks such as the CAR, the ACR, and choosing wisely to select the best test for your patient. And radiologists are consultants, and any radiologist would be more than happy to talk with anyone about what the best test is to image for their patients. So fundamentally, if you have a question, pick up the phone and call your local radiologist. That's what we're here for. Thank you. Next slide. And that's just my contact information. Thanks for coming, people who are here.
Thanks so much, Maura. Always wonderful.
Thank you.
So we have a question. Are you ready?
I'm ready. I'll do my best.
Okay, here we go. Here we go. Hi, Maura. Great presentation. Extremely informative. Are you able to provide a copy of the presentation? Oh, that's a simple one.
I think it's recorded, right?
Yeah, this
Yeah.
is recorded by the
Yeah.
coalition, so this will come out.
Yeah.
I see Autumn putting a link to a conference that we're having, the Canadian Coalition, in Montreal on August the 30th. This has been an SSE conference. Jerome Rabest is the chair of our board. He's run this for years now. It's going to be combined. And it's going to be quite exciting. We're getting a lot of international people coming from from the NHS, from the Nordic group, from France, from a few of the Ivy League schools. So yeah, you're more than welcome to come. Lots of thank yous here. If you're not seeing that, Maura, excellent presentation. Um, so no real questions yet. Let's see.
Well, I mean, my information,
Yeah,
you
yeah.
can take that slide down if you want to, but my information is there. I love this topic. I'm kind of deeply embedded into it now, and I really enjoy engaging with people because I really think that by talking about this and putting our minds together to come up with solutions that are thinking outside the box really requires everyone to come forward with ideas and suggestions and have discussions. And I welcome all discussions because, well, that's how we learn. And there's that saying, what is it? Culture eats strategy for breakfast. And I think we could say culture eats policy for breakfast. Like we got to change the culture. We got to change how we think about our healthcare system and how we provide care to patients to make sure we're providing the right test to the right patient at the right time consistently. And that's how we'll get policy change. I really think that. So I'm um, quite quite happy to talk to anyone anytime about any of this. Yeah.
So, Maura, here's one for you. You ready?
Yeah.
Okay, so I think you and I both like to think
Mm,
upstream, and one of the ways that I think upstream is the fact that in primary care, um, we have opportunities to talk to patients about advanced care
mhm,
directives and their goals of
mm,
care.
mhm,
And I often say in my lectures that I think 75% of Canadians want to die at home, but most of us end up dying in hospital. I think maybe
mm,
56%. Um, there's probably no ready number here, but I'd just be kind of curious. So, the whole goal, as far as I'm concerned, is the fact that we spend a lot of time trying to make the hospitals greener, and we should continue to. But
mhm,
we should probably have more emphasis on not having patients end up in hospital in the first
mm,
place because they don't really want to be there.
mhm,
And we have a population which is getting older and older. I think in 10 years or 15 years, the number of people over 85 years old is going to double.
mhm,
So we need to make a shift there. So I often look at, interventions you're doing upstream, you are
mhm.
stopping the admission altogether, and then you look at the greenhouse gas, equivalent of that admission. It'd be kind of fun to look at what is the greenhouse gas equivalent of radiology per admission,
Yeah. Well, I the
right? Because
as I
that's what we're
yeah,
doing by the upstream stuff, right? We're
yeah.
not even thinking about what investigation you're going to do if someone's receiving home care and has decided they're going to be
Mm.
palliative, right?
There are I think just in general, there would have to be so many assumptions to come up with an actual number because what people are admitted to for hospital varies so much from like one day, or to like months or weeks for various things. So I think actually the interesting way to look at that is patient pathways through certain disease entities or through like a certain surgical, like for a surgery for a schwannoma or something like that, like or a lot of the work that Andrea McNeil's done, for example, looking at how many times do you need to do blood tests on people that are having a certain type of operation. So I think
Mhm.
really to measure that, you'd have to pick a certain um, workflow, a patient being admitted for, bowel surgery or something like that, and look at how many times imaging is used and are there areas in there that we can do less of it and not impact patient care adversely. And then you'd probably have to go from there. You'd probably start with something very specific. The project we're doing at BC Cancer is very specific to a certain tumor type in a certain group of oncologists. We hope that what we learn from that in terms of the engagement process and, building confidence amongst our peers and how to talk to patients and all that sort of stuff, will be able to enable spread and scale across other tumor types and other jurisdictions, but we don't know that yet. But you have to start somewhere. So I think starting with a certain patient pathway and measuring that. And this is going on in lots, like the NHS is doing this work. There's lots of places that are doing patient pathway specific work on where the carbon hotspots are, and then expand
Yeah.
from there and spread and scale to other jurisdictions doing the same procedure, or take the learnings from that procedure and adopt it in other workflows. So there's kind of both ways you can use that information, but to get one number is really challenging. Yeah.
Okay, thank you. A bunch of questions coming in now,
Oh,
Maura.
wow.
Something is said. Something is said there. Let's see here.
Yeah.
Okay, so first one here. What are your thoughts on AI in diagnostic imaging and its carbon
Ah,
footprint?
the question of the hour, day, month.
Yeah.
Um, I guess all I can say at the moment is we don't know. It depends. Obviously, the data centers are a huge negative, but if we can use that AI, for example, the the MRI scanner that we have right now has an AI program that can do some of the image reconstruction so that we can shorten the time on the scanner for a head MRI from 40 minutes to 20 minutes. So if we can use that AI program, then we can reduce the emissions per patient for that exam. Um, so this hasn't been measured. It's a huge question, and lots of people are asking it. If we can use AI to reduce duplicates, to find similar exams using natural language processing, so that we don't repeat studies on inpatients or people. Sometimes patients. Providers will submit a rec to like 4 different hospitals looking for the earliest available appointment. So if you can use AI to centralize that so that the rec just goes to the next spot wherever it is within an hour's drive or something like that, then there's benefits to the patient and to the system. So I think the jury is still out on that. I don't think we have enough information yet, unfortunately. It's a great question, and I get asked that all the time.
I'll bet. All right, next one. Would it be fair to say that emissions related to radiology
Yes.
would be grid dependent?
Yeah.
I
Yeah.
think you did have a
100%.
slide that you
Yeah.
talked about there. Yeah.
I did. And that the paper from Thiel and colleagues in Vanderbilt is from a fairly high intensity grid. I think they use a lot of coal and natural gas, whereas here in BC, our grid intensity is really low because we have like 97% hydro, at least for now until we have a drought. But at the moment, we still have mostly hydro. So our grid intensity is very low. So the work we're doing here in BC, yes, it reduces emissions, but it more importantly, here anyway, reduces how much electricity we use. If we reduce the waste of electricity, then we have more electricity available in the system to decarbonize transportation and buildings and such. So even if you have a low intensity grid, it's still really important to reduce the waste. But yes, that's a very good question, and you're completely correct. Yeah.
How would you recommend health systems build sustainability criteria into imaging RFPs without compromising workflow or clinical priorities?
Mm-hmm.
And do you have a sense of receptivity from industry?
I think all of our vendors are really interested in this, and for many reasons. Clients want it. More people are asking for it. When you refurbish the big machines, for example, you can save 50% in the emissions, but you can also save hugely in the cost, which is a concern for everybody, how much this equipment costs. And I think that so we have a lot of support from vendors, and it's also the right thing to do, and they know that. And so there's a lot like the interface between the end user, like myself, and the providers is really important. And having the vendors come to the table wanting to work together is just like makes my heart warm. It's just such a great thing because that's what we have to do. We can't, neither can do it themselves. And I think most of these situations, the second part of the question is workflow or clinical priorities. I don't think it's a trade-off. I think it's a win-win in so many of these situations. Vendors providing multi-dose contrast dispensing units. Now we can like save money, reduce waste, reduce the waste of like iodine getting into the environment, reduce the cost. Like there is no downside. Um, and I can't remember where I read it, but a couple years ago now, they looked in the NHS and they found that, I'm sure someone here would know this, but roughly 80% of low carbon projects are cost neutral or negative. So they save money right off the bat. Like say you decide to no longer use exam table paper in your clinics on your exam tables, then you just save money. And then 20% that do cost some money had an ROI of about 3.5 years. So even if you have to invest in something like a multi-dose contrast dispenser, the ROI is tight. And I don't know that that one's 3.5 years. I don't know that they actually looked at that part of the equation, but most of these things, even if there is a little capital expense, it's paid back quite quickly, is the message. Yeah.
I'll let you catch your breath this time. Um, For someone who's early in their journey learning about environmental impact of healthcare and would like to get more involved, what suggestions can you offer for mentorship and involvement? And I'm not
Ah.
sure if that's specifically for radiology or for this space in general, but go ahead.
I'm a huge fan of CAPE, the Canadian Association of Physicians for the Environment. They do amazing work, and they have an amazing group of physicians who are just so knowledgeable, and a great place to start a learning journey. Because I think fundamentally, it's important to understand the health impacts of the climate crisis because that's what gives us motivation as physicians to be able to speak with some authority about why it matters to us. And that's fundamentally our strongest voice is saying this is impacting health of people, communities. When we breathe polluted air and we drink polluted water, it impacts the health of our communities and it impacts global health. But that's a way that you can have some authority and a way that you can engage others because everyone cares about health. So, and then the Canadian Coalition for Green Healthcare has an amazing list of resources. So, depending on where your interest is, I'm sure Miles has something for you. But those would be two of the biggest. Put a little plug in for the Canadian Coalition. And then, of course, Cascades has a bunch of playbooks to read through. And there's also introductory courses. There's some online introductory course now that I think is not too long, and it's a really good explainer and a place to get started. Yeah.
Excellent. Autumn, do you want to throw a link to our hubs in there? All right. I struggled to try to get my team on board and get buy-in to include sustainable practice as a core
Mm.
competency in clinical practice standards, example, video fluoroscopy. It is felt that this is a task for a different department. How do you
Mm.
advocate for inclusion?
This is so important. And I think really fundamentally, it's the collaboration and cross-disciplinary work. So I co-chair the Planetary Health Unit for BC Cancer, and we've been having success for 4 years now. And I think one of the biggest reasons that we've been successful is that it's uh, it's co-chaired between me and a senior operations director for BC Cancer. So frontline clinicians, we see the waste, we see the plastic going in the garbage, we see the scanner sitting idle. Um, but it's really hard sometimes to know who do you contact on the procurement team or who do you talk to about changing to video fluoroscopy. I think you need to have the operations team who know the people, someone high enough in the organization that they have connections and they can help introduce you to the right people to set up a team. And so putting together a little green team that's as diverse as possible, and making sure that everyone on the team is on the same page in terms of why it's important. So the education under sort of sustains everything. And then working together to reach out. It's hard to get started, but having an interdisciplinary team with different people that have different connections and different ideas is really helpful to get us sort of out of the silos that healthcare tends to be in. We're so good at what we do and we're very siloed in our approach, but we have to kind of break down those barriers in order for us to really think differently and think outside the box to solve these problems. I hope that
All
answers your
right.
question. Yeah.
That's great. So it's 12:28, and I know you've interrupted something else in your day. More to come, and I really appreciate it. Great presentation. A
Thank
few
you.
more thank yous and a big shout out from Dr. Stoyanova. Um,
Thank you.
yeah, thank you again, Maura, and thanks everybody for coming today.
Thank you. Thank you, everybody. Thanks for the
Yeah,
opportunity to talk.
yeah.
Bye.
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 Thanks, everyone. Bye.
Thanks. Bye.